Over the course of my career as both minister and physician, I've been very interested and concerned about health disparities, racial and ethnic health disparities. And one of the most glaring disparities that I've seen over the last 30 years has been around the issue of infant mortality rates. I think everyone is coming to know, African Americans are disproportionately impacted by infant mortality. And in Memphis, Shelby County, the rates are almost 3 to 1. The rates of a mother who is African American having a baby die before reaching the age of 1 versus her white counterpart. As both physician, academic physician, public health physician, one who was recruiting physicians to go back into the African American community, and as a pastor here in South Memphis, I really became concerned about the disparity and more so what we can do to address the issue. Obviously, while I was the state health commissioner, it was a high priority for me. I was very grateful that Governor Bredesen made it a high priority. It is one of the reasons that we were able to get funding in Shelby County for the Office of Early Childhood and Youth, particularly to focus on the infant mortality reduction program. Shelby County is unique in the sense that we have some of the highest infant mortality rates in the nation here. And that's a problem that is multifaceted. It's a social issue, but it obviously has both clinical implications for the mother and the baby, but wide-ranging implications for the communities that really suffer the impact of baby death. Well, I have a pretty eclectic background. While I was in medical school at Harvard Medical School, I was called to preach. And so for the last 3 years of my Harvard Medical School days and going into residency as a general primary care internist, and following that, I've been exploring the interface between faith and medicine. I practiced as a general internist. I soon thereafter, after about 10 years of practice, became an academic physician, really interested in recruiting African American physicians who really needed to be able to go back into communities of lower socioeconomic status and to take care of people in an increasingly diverse population. And so as a physician, I've been a practicing physician, academic physician, and in 2003, Governor Bredesen invited me to come and be the Commissioner of Health for the state of Tennessee. So I spent a term, 4 years, in the governor's cabinet, really overseeing the pretty vast public health network in the state. The reason I think he invited me was that over the course of my professional career, I've actually explored my professional life as a minister, as a pastor, in local congregations in the African American community. I'm an ordained elder in the AME Church, the African Methodist Episcopal Church. And here in Memphis, I'm the pastor and the chief executive of St. Andrew AME Church. One of the things we've come to understand is that the process of gestation, the internal environment inside of a mom for a baby to be born is a very complex process. It seems uncomplicated for people that have normal deliveries all the time, but apparently there are elements for African Americans, elements that are related to stress, elements that have other clinical correlates, and certainly there are those extraordinary linkages between infant mortality rates and poverty. And so when you have what is almost the perfect storm, African Americans that have some inexplicable elements that lead to higher infant mortality rates, high levels of poverty, low socioeconomic status, and some of the other components that we know are part and parcel with causing prematurity, low birth weight babies. In other words, decreased access to health care, decreased access to prenatal care specifically, other correlates in terms of very poor maternal health, maternal preconceptual health. That becomes a perfect storm. Young moms, moms that did not plan pregnancies, not only teenagers, but young adult women also who are not spacing their pregnancies. persons who have poor literacy, much less poor health literacy, who are not aware of the implications of their poor health and poor decision making upon those children that are still in their wombs. So it becomes a very complex issue, all of those elements coming together to generate higher levels of infant mortality. Because infant mortality is so complex, because it is an issue both in terms of value and virtue, decisions that we make, as well as a clinical issue. When you have the faith community in a place like Memphis that is as prominent as it is and as integral in the social fabric of a city, then the faith community can become a very powerful intermediary in terms of both reaching young women who can be pregnant and are pregnant, and in really setting a tone and changing the social mores and the behaviors of a community that might either lead variably to maintaining high infant mortality rates or addressing infant mortality rates. So I've been very gratified over the years as both just a practicing physician and pastor, and as commissioner and now as a public health advisor, to see that churches, that communities of faith are coming together to recognize that if they can increase the awareness of their congregation and the communities around their congregation, that it is a problem, number one, then there are elements that can be put in place. Young women can be taught to plan and space their pregnancies. Young women who ought not be pregnant can be inspired and mentored and taught and given alternatives to becoming pregnant too early. Adolescent moms have an even higher rate of low birth weight babies and infant mortality than older women who have unplanned pregnancies as well. If the clergy persons in faith communities are aware that there are pregnant women in their congregations, then this can generate an entire cascade of approaches as well to go and get those pregnant women, get them into prenatal care early, since we know that babies who die before the age of 1 have moms who disproportionately don't seek prenatal care in the first trimester. Only about a third of women in Memphis, Tennessee, whose babies die sought prenatal care in the first trimester. So clergy persons can find pregnant women, encourage them to get into care, and in addition to that, help them make all the appropriate decisions that are going to likely increase not only the possibility that the baby will be born healthy, but that the baby will stay healthy after birth. One of the things that we're very pleased about is that I think in the faith community there are increasingly numbers of churches that are sponsoring what we're calling community baby showers. They're opening their doors to pregnant moms and moms who have newborns, and taking those opportunities, yes, to give them gifts and to show them that they are cared for by that church and that God loves them, and perhaps meeting some needs economically for them, but also to introduce them to resources, to teach them about car seats, to teach them about decreasing the stress in the home so that there is a lower likelihood of child abuse and other stressors that might impact the well-being of that child. To introduce them to the value of breastfeeding, because we understand for newborn babies, clearly breast milk is the best food. And so for moms that may not have had that opportunity to hear that, to be mentored in such positive ways, for either the babies that are yet to be born or babies that have just been born, all of those interventions make it much more likely that that baby will make it to that first birthday as well. And it's been wonderful to see churches open their doors, have these baby showers, bring in the agencies, bring in the experts, bring in the other community voices that can really interact with those moms and help them be prepared to help their babies survive. I think in theory, all of the approaches to intervene at appropriate times in the lives of women who are either going to be pregnant or who are pregnant, all of those approaches can be successful. What I really have appreciated is the value of programs such as Centering Pregnancy, in which we have moms who are there with a cohort of other mothers at a similar point in their gestational age who are supporting each other. So there's peer support, and they're getting very good hands-on, caring health care and encouragement from a healthcare provider, a nurse, midwife, or nurse practitioner trained in centering pregnancy. And the combination of the peer support and the loving hands-on both clinical and social support of a practitioner has helped these young mothers understand, A, what's happening with the pregnancy that they are currently engaged in and how they might be successful moms and to keep those babies healthy once they're born, but also B, how they might project a different trajectory in their own lives so that they may not get pregnant again in an unplanned fashion, that they could space out their pregnancies, and really that they could turn the corner in some of their own plans for their lives, improve the lot of the child they're about to have, and then perhaps be a little bit more deliberate in terms of planning their family going forward. Those have been some of the best examples of how young women will say in their own testimonies, I wish I had known then what I know now, and I'm so grateful for this kind of support and intervention. Great story. I think community voice has also been very successful. The fact that we've been able to train lay health advisors to understand about infant mortality and to be in their communities to encourage women to stay well and be well and improve their preconceptual maternal health, keep themselves well, and be better prepared to be pregnant when and if they get pregnant. Very, very helpful models, community voice, centering pregnancy. When the world became aware of the problems that we have in Memphis and Shelby County in terms of our adolescent pregnancy rates and our infant mortality rates, it was not news to us in Memphis and Shelby County. I'm sorry and I regret greatly that it appeared to others that there was a cluster of adolescent pregnancies in a certain school in Memphis. And as is often the case, only half of the story was told. It wasn't evident that there was a school that actually was a magnet and that actually had programming and curriculum geared for pregnant and parenting teens. And so there was a cluster of pregnant girls at that school. It was not that there was a problem. It was not a tsunami of pregnancies at that high school. So I was sorry that the whole message and the whole story was not appropriately carried. However, it is not news to us in Memphis and Shelby County that we have an issue with adolescent pregnancy. Our adolescent pregnancy rates are high, our adolescent birth rates are high. It is not unusual in the African American community, and it is the kind of issue, and it is a point, it is a wedge for us in both the faith community, for those of us who are concerned about social determinants of health, and for those of us in the clinical community to understand that we must get a good handle on our adolescents. We must be able to get their attention, must be able to speak honestly, openly, have transparency in terms of sex education, family planning, that we cannot play the ostrich, we cannot be in denial. And so while those articles and those news stories and the media blitz was to some extent painful and perhaps hyped as it should not have been, it was always helpful for those of us who've been saying this in multiple arenas to drive focus again on the fact that we have a problem and that the community must come together in a multi-sectoral way and address the problem. I'm very hopeful about the future of the lives of babies who are born in Memphis and Shelby County, and the lives of babies who are born in the families of African Americans in Memphis and Shelby County. I'm hopeful because awareness is at an all-time high from moms, from future moms, from persons who are integral in the lives of pregnant and potentially pregnant young women, persons in the faith community, people in the clinical community. We are all aware of the problem. Awareness is key. There was a time, I think, when some of us were tilting at windmills, and some of us were out there crying in the wilderness, and no one got it. No one understood disproportionate impact. No one understood some of the elements that are preventable, and no one understood how to intervene effectively and to begin to change the statistics. That's not the case any longer. I think one of the reasons we're delighted about the Shelby County Government's Office for Early Childhood and Youth is that governmental entities get it, that our elected officials understand, that there are resources, both public resources and private resources, being directed towards turning the tide. That's very hopeful. We are clear that there are components of infant mortality that we simply don't understand. It is one of the reasons that there is perhaps an unprecedented amount of research being now devoted to the topic at the Centers for Disease Control. It is one of the reasons that there are persons from many different agencies, entities, and disciplines, from social work to governmental public health, all thinking about how to improve the lives of moms who will ultimately get pregnant, and then how to get pregnant women into appropriate care. I'm very hopeful because when we look back and think about the evolution of neonatal intensive care units and how far we've come over the last few decades, and the lives of babies that are not being lost because of the extraordinary tertiary care that little bitty babies are receiving, perhaps born prematurely, perhaps born low birth weight, but now they are making it to their first birthday. So there are many things out there, I think, that are the cause for great hope. Our prayer is that the social determinants, which are also integrally involved in causing the levels of stress and the issues that lead to infant mortality, might also be addressed. That's going to be a generational approach. It's going to take some time, but because I know that there are others out there who share my view that infant mortality is a social issue and not simply a clinical issue, I think we're on the right track.